This is MRI T2 weighted image. I can see hyperdense of the brain. Axial sections, I can appreciate there are hyperdense head of the caudate nuclei and putamen. Thalamus is normal on flare sequences. These are hyperintense, showing hyperintense signals, and on sagittal um, images, hyperintensity in the pons is also noted, and this is showing diffusion restriction on ADC. And on contrast, now enhanced. This is T2, so axial T2. The midbrain is showing two hypo intense signals. So some metabolic disease. So, it can be due to some lead poisoning, or differentials would be central pontine myelonolysis can also give this appearance. Carbon monoxide poisoning.
His siblings are also affected. Dr. Ihtasham, kindly मुझे 15 minutes बाद बता दीजिएगा, because we are also already short of time.
All right, ma'am.
This is 29-year-old female, multiple falls and broad-based ataxic gait. This is MRI sagittal section, T2 weighted image.
Just keep
I
on.
can appreciate there is cerebellar atrophy, no tonsillar herniation seen. On the axial sections, brain, T1, fat set. I can appreciate there is hyper intense signals in the cerebellum, and temporal left temporal region shows hypointense signals. On ATC mapping, it's showing diffusion restriction.
What comes to your mind? These are the previous images.
Cerebellar atrophy.
Okay.
Next image, ma'am.
So in this case, would you like to do anything else? Go back to history.
Broad-based gait and ataxia. So these are the axial section. These are the sagittal section, spine, thoracodorsal spine, axial and axial sections. T2 weighted image. No hyperintense signal is seen in the spine.
Okay, spine was normal volume.
And no other lesion seen.
Okay.
Radicals and other.
Okay. Let's move forward.
This is 63-year-old female, diabetic, hypertensive, chronic kidney disease with uremic encephalopathy, Glasgow Coma Scale 7 by 15, CSFRE normal, CT brain no infarct or hemorrhage. This is an image of a sagittal section brain, T2 and T1 with contrast. Um, um, I can see hyperintense signals along the cortical um, frontal in the frontal lobe. In the cortical, there is loss of gray-white matter differentiation on the in the frontoparietal region, and the orbits are normal. The spine, included section of spine is normal, so this can be an infarct, early infarct. Next, I would advise MRV uh, or MRA and MRA for the patient.
I have few more images. Just see them. This is
The
artifactual.
ADC.
Senior.
This is DWI and ADC. In the flare images, I can appreciate there is a hyperintense signal in the posterior occipital lobe on both sides, and some high signals are seen along the left white matter left side of the midbrain. So these changes are of posterior reversible encephalopathy, press, although I cannot. 3 years old female, left proptosis, 2 months, intraocular pressure 18 millimeter of mercury. And these are the ultrasound images, B scan, and the left globe is, I can see there is the optic nerve is thickened and um, fusiform in outline, and this is a Doppler image with waveform. On this MRI T2 weighted image, the left optic nerve is thickened, and this is case of optic neuritis, and other differentials would be optic glioma and meningioma, but meningioma shows avid enhancement on post-contrast scans.
This is avidly enhancing. This is
And with
sequence is this?
This is 3D T1 weighted fat set.
And this one?
Contrast enhanced axial T1. So the left optic nerve is showing avid enhancement. So I will reverse my findings to optic nerve meningioma. And next, I would like to see I will do the workup for NF2 to see other meningiomas in the brain and any other acoustic neuromas. This is 11-year-old female, fall from 15 feet, landed on feet. These are the X-ray foot, oblique and lateral image.
No, this is the right. She landed
This
on
is right and
right foot. This is the left.
okay, ma'am. And this is unfused skeleton, immature skeleton. I can appreciate there is a comminuted fracture of the calcaneus. These are the X-ray thoracolumbar spine, axial and lateral view of a child.
Same patient.
Acha. I cannot. Acha. The pedicles and vertebra in view are normal. Ribs, no rib fracture seen. On the sagittal view, I cannot appreciate any fracture. Spinous processes are normal. Pedicles are normal. Vertebral heights are normal.
Okay. I
Sacral
think
vertebra.
आप लीजिए.
Mm, Sacral, the first sacral vertebra are reduced in height.
Okay. 7 cases हो गए? नहीं, you have 1 left. Okay. Quickly.
This is 64-year-old female, fall, 1 year muscle strength, 5 by 5 lower limb reflexes absent, saddle anesthesia, sensory level T10, planters mute. Um, collapse of the vertebra. No paraspinal collection seen, and the posterior elements. I cannot appreciate the posterior elements in these images to see a fracture. It's compressing the spinal cord at this level, and so this
Ma'am,
is
5 minutes
compression
left
collapse,
in this.
post-traumatic compression collapse of the vertebra
Okay.
of D12 vertebra with spinal cord compression.
Okay. So, okay, let's, we can review your cases now.
Yes, ma'am.
Can give you the feedback. Okay. So, yes, you were right. You couldn't evaluate the posterior elements because axials have not been given. Just let me know, is it acute or chronic?
Acute.
Which sequence is this?
This is T2 fat set.
Stir. Okay. This is T2, this is T1. So you should, एक तो history में ही देख लेना, fall 1 year back. And she has saddle anesthesia, sensory level 10. So 1 year is not acute. There is no edema. Can you see any edema here?
No, no.
Okay, so nobody would be presenting simple collapsed vertebra post-traumatic with this spinal stenosis. Actually, the catch was the urinary bladder. Look at the walls.
Yes, ma'am. These are trabeculated.
Yes.
So neurogenic bladder.
Yes, post-traumatic. Okay. So the calcaneal fractures are so significantly associated with lumbar vertebral fractures. See, this is L543. You can see the crisp outline of the rest of the vertebra. Where is the lower outline of L3? 5, 4, 3. Just see the anterior wedging. So for any calcaneal fracture, you have to evaluate the spine. Don't send the patient back home with a back slab and just the orthopedic evaluation.
Okay.
And you were on the right track. This was, just look at the age, 3-year female, left proptosis. So meningioma कहाँ से arise करता है? Meningioma arises from the meninge. It's the optic nerve itself. So it was avidly enhancing. And NF, किसके लिए workup करेंगे?
NF2. NF2.
No.
NF2.
NF1. बच्चा है ना? और just look at the optic. Another differentiating point is that optic nerve glioma widens the optic canal. So she did not have any. Which sequence is this?
This is T2 fat sphere.
अच्छा, ये आप आगे भी आएगी तो फिर वहां हम डिस्कस करेंगे, ठीक है, नेक्स्ट कैंडिडेट के साथ. सो दिस वाज यस, प्रेस यू डायग्नोज्ड राइट, बट मिड ब्रेन, दिस इज मिड ब्रेन, ये आपको यहाँ भी दिखाया था, मिड ब्रेन हाइपर इंटेंसिटी. एंड व्हाट इज दिस इमेज?
Axial T2 star
Star.
GRE.
This is to look for.
Blood.
Yes. So this
Incoming
was just to
artifacts.
show that this hyperintensity did not contain any blood. So press was, yes, it goes with the history, but press is very unlikely in midbrain or pons. So hypertensive midbrain brainstem encephalopathy versus press. So what to do next? It's an emergency. What to do next? Both are associated with high blood pressure. He is a hypertensive.
Next, we can go for MRA and MRV to see any.
No.
And hypertensive treatment.
Yes, it's a red flag. You have to inform the management team, and just for confirmation, you can do a repeat MR after treatment. So that will confirm it. So it was not a stroke because there was no diffusion restriction. You see, this hyperintense, swollen abnormality did not give any restriction. So it wasn't a stroke. It was press versus hypertensive encephalopathy. It's an emergency. So you picked it well. 29-year-old, there was cerebellar atrophy, and there was calcification in the dentate nuclei that did not show diffusion restriction. This wasn't restriction, this was facilitation. And the cord was normal. So the typical history, the typical age group, spinocerebellar ataxia. History is very definite. So this was Wilson's metabolic. This you can see. What appearance is this?
Eye of the tiger appearance. Panda, giant panda appearance.
Yes. So where is this abnormality?
Midbrain.
No, midbrain, yeah. This is midbrain.
Pons,
yes, this is pons. So pons is restricting, and midbrain has this appearance. So this was Wilson's. I told you his siblings were also affected. And second case, what was this? This
corpus callosum, high signal
the
intensity.
splenium. Just look at the splenium. And this is not pons. These are normal phloboid. This was the abnormality. So what are these? What are these veins? And it was restricting. I don't know, left side pe, what did you find the restricting area? This midline splenium of corpus callosum was restricting. It wasn't, just see this faint hyperintensity on T2 again.
Yes, ma'am.
Not much on flare. So this was a cytotoxic corpus callosum lesion. So this is also reversible. You can do, you could have said differentials of focal infarct, but infarcts of corpus callosum are very rare. So you can again follow them up. The etiology was seizures. You can follow them up and they will go with control of seizures. Okay, let's move to candidate. Next candidate. We have to be really quick. Next candidate is with us, Dr. Etesham.
Yes, sir. Yes, ma'am. Candidate number 64, please unmute your mic.
Okay.
Yes, ma'am.
Okay, welcome. Next candidate. Let's start.
Thank you, ma'am.
You can read out your clinical notes.
I've been provided with a patient, which is a 4 years old male, and he's having a loss of vision with leukocoria.
All right. So this was February 2023.
Actually, ma'am, I have to say something. Actually, I'm MCPS candidate, so I won't be able to study the MRI
Okay.
properly.
Okay. So this is the signal abnormality. This is, I'll just go through very quickly. This is the signal abnormality, which is based on retina. And this is the abnormal signal.
Yes, ma'am.
Left eye was normal. This is right side, sagittal.
Yes, ma'am.
Sagittal T2, and this is sagittal post contrast, where we can see this enhancing focus. This is cysternography sequence, which is specific for nerves. Then the patient had enucleation, and we can see this enhancing area within the region of residual optic nerve.
Yes, ma'am.
Histopathological, so I'll not tell the histopathological diagnosis yet. This is T1. This is how the enucleated eye looks. And post contrast, we can see the enhancement. Left globe was normal. So sagittals, we see enhancement along the subarachnoid space as well as in the region of optic chiasm. This was the residual optic nerve, and rest of the orbital fat also showed enhancement. So this was primarily a retinoblastoma, proven histopathologically, which was resected, and in a year he presented with, after removal of the globe, he presented with recurrence, and this time he had subarachnoid seeding as well. So let me check. I'm sorry, I have all MRI.
I think they have FCPS candidate as a backup, so the co-host can ask them to.
Dr. Kasham, what to do?
Yes, ma'am, we do have a backup candidate.
Okay.
Yes, ma'am.
Backup candidate.
Thank you, madam.
Okay, good luck.
Thank you.
Backup candidate number 6, please unmute your mic.
Assalamualaikum, madam.
Ji walaikum assalam. Let's start here.
Okay, madam, I'm provided with 2 MRI sequences of 18-year-old female who presented with headache. These are the DWI and the ADC mapping images. Here I can appreciate the large abnormal MR signal intensity area that is involving the left frontal temporal lobes, predominantly involving the subcortical white matter and with sparing of the cortex. And this is showing the facilitated diffusion with subsequent mass effect on the underlying ventricular system and subfalcine herniation. On the T1 weighted image, it is hypointense and with a small amount of the leptomen enhancement on the post-contrast images. I cannot appreciate significant enhancement in these images. Okay, and flare and the T2 weighted images, there's a demonstration of this large amount of the vasogenic edema and with the similar effect on the ventricular system and subfalcine herniation. So in an 18-year-old female patient, I'm suspecting it, then this is an aggressive disease process that had resulted in the vasogenic edema, could be due to an underlying mass. And that could be a high-grade glioma, but there is no significant enhancement in this patient. Other possibility can be any. Yes, madam.
Okay, we move on to next.
Okay. It is 23-year-old male patient who presented with road traffic accident. I'm provided with the CT brain plane images. Here I can appreciate diffuse cerebral edema with effacement of the sulci and chiral pattern with hyperdensity, focal hyperdensity also noted in the left thalamus. I'm also suspecting there is evidence of the intraventricular hemorrhage as evident by a fluid level in the both posterior horns. Okay, and the sagittal images, I can appreciate there is a hypodense area noted in the involving the splenium of the corpus callosum, And apart from, I'm suspecting that there is hyperdensity in that and along the tentorium cerebelli. On the T2 weighted images, there is a redemonstration of the hyper-intense signal in the perineum of corpus callosum, pons and the pons cerebellum, and some areas of the subcortical white matter in the cerebral hemispheres. मैडम यही images हैं?
No, I have these.
Okay. So on the graded images, there are some evidence of the blooming artifact along the periventricular surface in the bilateral hemisphere that are showing the diffusion restriction, a true diffusion restriction on the DWI sequences. On the basis of these findings, a post-traumatic patient, I'm suspecting these features are concerning for the traumatic diffuse axonal injuries. Madam, can you hear me?
Yeah, now I can hear you. Yes, I wanted to be quick. Sorry.
Okay, these are two images of the axial and the sagittal T2 weighted MRI brain of 32 years old female who presented with the headache. I can appreciate there is the enlargement of the and prominence of the subarachnoid space surrounding the bilateral optic nerves, along with the flattening of the posterior aspect of the sclera. There is the flattening and of the pituitary gland with some prominence of the subarachnoid CSF spaces in the cellular and supracellular region. Apart from that, I cannot appreciate any other abnormality in these two provided images. On the basis of these findings, in this patient, my top differential would be the intracranial hypertension in this patient. And
Same patient.
same patient?
Yes.
Okay, in these, I can appreciate that there is the increased enhancement of the pituitary gland and also the sinuses appears to be engorged with hyper enhancement. So these are findings that are consistent with the intracranial hypertension.
Okay, next case.
Okay, this is 1-year-old female who presented with swelling since birth. Okay, this is the one image of axial T1 weighted MRI brain. Here I can appreciate there is a lobulated hypointense mass noted in the preseptal space. This mass is lobulated, causing posterior compression of the on the orbit. And second image is the post contrast, and it is showing the avid enhancement with some internal areas of the flow wide. Otherwise, the brain and orbits are normal. This is the T2 weighted image, and it is highly hyper intense on this sequence with the flow wides. On the basis of these finding, my top differential would be the orbital hemangioma. And next, I would advise this mission for vascular mapping to look for the vascular anatomy, and then we follow up this patient for self-resolution.
Okay, next case.
Okay, this is young female patient who presented with fever. Okay, in this this is the chest X-ray PA projection of an adult of a patient where the most striking abnormality I can appreciate there is the prominence of the reticulonodular shadowing with some bronchiectatic changes that are involving the both lungs, more in the left middle zone and also the right lower zone. There is evidence of scoliosis with convexity towards the right side. Apart from that, the cardiomediastinal contour are in normal appearance and cannot appreciate any other bony deformity.
Okay.
There
is history of fever.
Okay, this is the spot image of a contrast enhanced CT at the level of the maxillary sinuses. Here I can appreciate that there is a well-defined hypodense lesion that is noted on the right side lateral to the carotid vessels. This lesion is showing the peripheral ring enhancement, and similarly on the sagittal image, there is the demonstration of this finding. And
Okay, that's the
on
reason for her
the bone
fever.
window.
Mhm. So
Sorry,
we
madam?
found the cause. We have found the cause for her fever. Now look at this image.
मैडम अभी तक मेरे पास वो सीटी वाली इमेजेस आ रही है, उन्हीं की बात करनी है?
Gigi, there's a bone window as well. So
Okay.
on soft tissue
In-
window, we have found the cause of her fever.
Yes, madam. Madam, like there is a bony calcific density that is noted in the right paravertebral region in the, but I can't fit in the frame.
Okay.
Okay. These are the two images of the one is this coronal sagittal bone window of a patient of an patient. Here I can appreciate that there is the partial ankylosis of the upper cervical vertebrae. That is the C6 and C7, and there is also widening of the prevertebral space. I can appreciate that there is an air locule that is seen in the prevertebral space in the sagittal images. Looking at the coronal post-contrast images, there is a demonstration of and widening of right left side space with some rim enhancing collection that is noted. And apart from that, no other abnormality is noted. Some suspecting that in this patient there is a widening of the prevertebral soft tissue with an air locule, likely due to the infective cause. Could be prevertebral abscess formation.
Look at this image. Same patient.
Okay. In this patient, madam, there is a dilated vascular structure that is coursing behind the trachea, giving, and it has the retrotracheal impression. And
Okay, this is your last case. Can you hear me?
yes, madam. Okay, this is the spot image of a T1 weighted sagittal MRI brain, where the brain parenchyma appears normal. The most striking abnormality that I can appreciate there is the enlargement of the pituitary gland, and a small relatively hypointense nodule is noted within the pituitary gland. And a second image is the T2 weighted MRI brain, and this appears hypointense on T2, and on the dynamic contrast it is hypoenhancing as compared to the normal pituitary. Otherwise the infundibulum optic were unremarkable. So on the basis of these findings, my top differential diagnosis is the pituitary microadenoma. And
Okay, thank you.
apart from that, the brain
We should-
parenchyma appears.
Okay, we should now revise. Most of the cases, in fact, all cases were well picked up. Okay, यहाँ तक हमने कर लिया था. Yes, this you picked it well, but it wasn't high grade. There was no restriction and no contrast enhancement. The catch was here. What is T2 flare mismatch? And what does it indicate? You see this bright area on T2, but it is not bright on flare. Can you hear me?
Madam, ये मैंने पढ़ा हुआ है, but I can't. जी मैडम. मैडम
it is highly
मैं रिकॉल नहीं कर पा रही है.
जी, ये diffuse astrocytoma है, and it is very, very diagnostic. In this age group, there's no restriction. Matlab you should not have called it a high-grade glioma. So this is very, very pathognomonic of astrocytomas. This is diffuse, but low grade.
Okay.
So this was, you should have picked up the, अब मैं ये देख रही हूँ, you people do not pay attention to the corpus callosum on axial views. So this should have been picked on axial. This is planium, but and an emergency. So brainstem was also involved. This was diffuse axonal injury. And see, this is not paraventricular. You said it's along the ventricles. This is the corpus callosum.
Yep.
And then, yes, this was the idiopathic intracranial hypertension. This was the cause. वहाँ हमने सही pick कर लिया, but when I'm showing you the CT venogram, this was the cause of her hypertension, intracranial hypertension. This was the filling defect in superior sagittal sinus. This was good, well picked up. You have to just follow them for involution. Usually they involute on their own. Okay, on chest x-ray, the posterior ribs are very, very horizontal. These are crowded here and a bit curved. So she had an abscess, but what are these?
Madam, external auditory meatus.
Are they normal?
Ma'am, atretic or stenosed है.
Yes, she had multiple congenital anomalies. So look at the fusion of the vertebrae, and here these were the external auditory canals. And when a patient has, look at this, the clivus, the platybasia, and no vessel arises from medial side of aorta. So this was anomalous origin
Okay.
of
Madam, ये posterior trachea तो right subclavian artery.
Yes. So this was Klippel-Fehl anomaly, and when a patient has one congenital anomaly, there are others as well. So she had atretic ears, this anomalous vessel, and then look at the fused vertebrae and the posterior elements.
Great.
So this was fine. You should know how the dynamic pituitary scan is done. You have to comment on the stalk and the optic chiasm and rest of the points. Okay, thank you. Next candidate. We are in a hurry, please. 8 minutes left. Dr. Etasham?
Candidate 65, please unmute.
Assalamualaikum, ma'am.
Ji, walaikum assalam. Shall we start?
Yes, ma'am.
Okay, Bismillah ar-Rahman ar-Rahim. So this is an elderly lady.
I am provided with the X-ray chest frontal projection of an elderly female patient, in which I can appreciate there are multiple calcified opacities are seen in the pretracheal region, along with soft tissue component. Visualized bones apices appears unremarkable, and cervical spine shows straightening. On MRI image, there is a multilobulated hyperintensive intensity area in the region of the thyroid gland, which is involving both the lobes and isthmus also. With internal hypointensities. This is post-contrast image of the same patient, in which is, it is arising from the spinal canal. avidly enhancing component. Mm, it is causing contralateral shift of the cord with the mass effect on ipsilateral muscles of the back. There is a central hypointensity on coronal images. मैम ये मुझे थायराइड का लीजन लग रहा है
Okay.
कैल्सिफाइड
Okay.
मल्टीनोडुलर गॉइटर बट मैम जो पोस्टीरियरली इंट्रा स्पाइनल जो कंपोनेंट आ रहा है वो वाइडनिंग कर रहा है न्यूरल फोरामिनास की न्यूरोफाइब्रोमास लग रहा है मैम ये डंबल शेप की ओरिजिन है इनकी
Okay. Okay, we can go on to next.
Yes, ma'am.
Look at the history, please.
Fall. 67 female. I am provided with the frontal and lateral radiograph of lumbocervical spine of a skeletally mature old age patient with history of fall, in which I can see there is a compression collapse of LV one vertebral body, which is involving all the three compartments, anterior, middle, posterior elements also. On MRI, T1 weighted image and T2 sagittal images. I can see there is edematous changes involving the vertebral body of the same level. There is a mild retrolisthesis at this point. मैम ये मुझे ट्राई कंपार्टमेंट फ्रैक्चर लग रहा है
Okay. ठीक है, let's move on. History.
43 years female, visual disturbances. Okay. I'm provided with the FLAIR axial image of a female patient in which I can see there is abnormal signal intensity areas involving bilateral parietal lobes, cortical and also in periventricular region. Also, it is also involving the left frontal lobe. On coronal sagittal MRI images, these are T1 post contrast image and sagittal T2 weighted images. Visual disturbances.
So what goes well with the history?
Visual disturbances के साथ optic nerve, right optic nerve is blurred.
Same patient.
Same patient. Same. These are T2 sagittal and axial images of the same patient, in which there is a hyperintense signal intensity area involving the cord, which is extending at the multiple levels. However, vertebral bodies appears unremarkable in these provided images.
Okay.
22.
Okay, let's move forward.
Yeah.
He's a 73-year-old male.
Okay. I'm provided with the axial CT scan image of a 72 years old male patient in which I can see there is a hyperdensity involving the bilateral periventricular regions and also along the both bilateral sylvian fissures, and there is a loss of brain white matter differentiation. It is causing mass effect on the ipsilateral lateral ventricles and showing a mild edema adjacent to it.
What comes to your mind?
Minimal midline shift भी हो रही है. Is there any history of ma'am, can I ask the history of the patient?
Low GCS and loss of consciousness he was presented with to emergency.
Emergency. Hyperdensities thalamic को involve कर रहे हैं basal ganglia. On HRCT chest, there are multiple areas of ground glass haze involving bilateral lower lobes. A heart appears unremarkable and bones are normal. Ma'am, hypertensive lesions हो सकते हैं, hemorrhagic
He is
infarct,
normotensive.
normotensive patient. On axial section of the abdomen, in which I can see there are multiple hypodense lesions giving target bullseye target lesions. Ma'am, these could be metastasis from the primary.
Okay, what is the primary now?
Ma'am, most common prostate in males and
This brain is plain. This is not post
brain
contrast.
plane. Ma'am, hemorrhagic mets.
Yes, they come from
CA prostate.
what is this?
Coronal T1 weighted fat set image.
Oh.
And there's abnormal signal intensity area.
What is this part of the body?
Ma'am, calcaneum, dorsal.
Okay. I am sorry we have to rush, but you have reached there almost. Okay. History?
Year-old female developmental delay. Okay. I'm provided with the frontal radiograph of skull, in which I can see there are multiple lytic areas involving the bilateral frontal regions, giving a look and chandel skull. On CT scan image, sagittal section, there is a soft tissue mass lesion involving the occipital region of the with internal with the break in the occipital bone. Developmental delay. There is loss of gray and white matter differentiation. Pediatric age group. Ma'am, there is dilated lateral ventricles and suggesting hydrocephalus in this patient. But मैम ये occipital lesion का समझ नहीं आ रहा.
Okay. क्या करेंगे?
मैम हाइड्रोसेफेलस को इमरजेंसी में मतलब ट्रीट करना चाहिए और इन्फॉर्म करेंगे रेफरिंग क्लिनिशियन को. to VP shunt.
Okay, I have a something here. Same patient. Can you add something?
Same patient. मैम cerebellar tonsillar herniation लगी है इसमें मुझे.
Yes.
मैम hydrocephalus तो है दोनों में, lateral ventricles and third,
Yes.
fourth भी dilated है.
Okay.
Sixty-one years female with backache. I am provided with the T1 sagittal post-contrast images in which I can see there is a large, well-defined soft tissue attenuation lesion. Which is avidly heterogeneously enhancing and causing displacement of the adjacent structures. It is arising from the left psoas muscle, and it's an aggressive lesion, soft tissue sarcoma, most likely.
Okay. Last case. History?
49 years old female, headache. I am provided with the DWI and ADC mapping images of a female patient in which I can see there is a normal signal intensity area involving the